Association of America, I would like to thank you for joining us today for this very special Ebola Preparedness webinar. I would like to first introduce UCAOA Board Officer and Education Committee Chairman Steve Sellers. Steve is CEO of Premier Health in Baton Rouge, Louisiana. He will speak to the management side of Ebola preparedness. Steve will then introduce Dr. William Gluckman for the clinical portion of the webinar. Please feel free to type any questions into the dialog box on your dashboard as you have them. We will address as many questions at the end of the presentations as we can. Again, I would like to thank you for joining us today, and now I'm going to go ahead and turn the webinar over to Steve Sellers. Thank you, Steve.
Thank you, Carla, and thank you for attending today's webinar. As Carla said, my name is Steve Sellers. I'm a member of the Urgent Care Association of America Board of Directors, and I currently serve as chairman of the UCAOA Education Committee. There will be two parts to today's webinar. During the first part, I will talk briefly about administrative considerations that our organization focuses on whenever an infectious disease like Ebola is a potential threat. I will then turn it over to the UCAOA Clinical Director, Dr. Will Gluckman, and he will talk in more detail about Ebola and what urgent care operators need to do to be prepared. So from an administrative standpoint, I'd like to start by saying that the goal of our infection control policy is for us to know how to deal with contagious diseases, to protect our patients and staff, and to make sure we have the right equipment, supplies, and protocols in place. At our company, having a plan, education, and communication are the keys to success when dealing with an infectious disease situation. We all know there's a lot of information and activity in the news media about the Ebola virus. And I think you'll all agree the worst thing any of us can do when faced with a threat is to create any kind of panic. As an urgent care administrator, I think one of the best ways to ease fear and instill confidence in your staff and patients is to have the right plan in place. We want to make sure our staff has all the facts and information they need and to understand how the situation could impact patients, the staff, and the community. During our planning process, we try to anticipate every aspect of what we might be dealing with to make sure that we understand the issue very well. Good, well-written infection control protocols will contribute to reducing the risk of acquiring or transmitting an infection. Our planning also means anticipating the need for specialized equipment and supplies necessary in an infectious disease situation. It also includes having and using CDC-approved cleaning supplies and disinfectants. If you have a cleaning service, you should check to make sure they're using CDC-approved cleaning supplies. With respect to education, all staff members should receive infection control training upon hiring, and education should continue on an ongoing basis to reinforce the importance of constant vigilance. We're always reviewing and attempting to improve our protocols. If it's necessary to make changes, it's important to retrain staff to make sure everyone stays current. We're fortunate to have an experienced staff member as the go-to person for coordinating our training and monitoring our compliance. She works very closely with our medical directors to make sure our clinics are up to date on all the latest guidelines and that information makes its way to our staff. She's charged with making sure all policies and procedures related to infectious disease and emergency response have been reviewed and are understood by all staff members. When it comes to communication, in addition to our regular training programs, staff members are a big part of our education, staff meetings rather, are a big part of our education and communications plan. They're a great way to make sure employees are getting accurate and updated information. They also provide an opportunity to review established guidelines and materials for infectious disease response and to discuss internal policies for the proper use of supplies and equipment. I can't emphasize enough how important it is for your staff to grasp what needs to be done should a potentially infected patient walk through the doors of your clinic. That interaction alone could set the stage for everything that comes after. Communicating with patients is also an important part of our communications plan. We have posters in our clinic waiting rooms listing the risk factors and symptoms associated with the Ebola virus. On the same poster, patients who have traveled to or near an area affected by the disease or who have had close contact with someone infected with the virus are instructed to inform the front desk staff immediately. It is also important to have a plan to reach out to infectious disease experts at hospitals and to other local, state, and federal officials. In any situation involving a potentially fatal infectious illness, it's critical to maintain those lines of communication to ensure a unified community response. So again, the keys to success from an administrative perspective are proper planning, education, and communication. Now, before I introduce Dr. Gluckman, I'd like to mention that the UC-AOA has taken a very proactive stance as it relates to concerns about the Ebola virus. If you've been to the UC-AOA website lately, you may have seen that a section of the site is now dedicated exclusively to providing urgent care operators and the public with accurate, reliable information, including facts and protocols related to Ebola. UC-AOA has also been on the front lines of media coverage about Ebola. In fact, representatives of UC-AOA have been interviewed and quoted extensively in media outlets across the country. In every case, the message has been focused on UC-AOA's efforts to prepare urgent care operators for every potential infectious disease scenario. The association has made providing information that will help members respond safely and appropriately a top priority. From a clinical perspective, Dr. Will Gluckman is overseeing those efforts, and he's also been UC-AOA's point person for many of the media interviews I mentioned earlier. Dr. Gluckman is the owner of Faster Urgent Care in Morris Plains, New Jersey, and serves on the board of directors of the Urgent Care Association of America. He also serves on the editorial board of the Journal of Urgent Care Medicine. Dr. Gluckman is residency trained and board certified in emergency medicine from Jacobi Medical Center in Bronx, New York, and has served as an assistant professor of surgery at UMD-NJ New Jersey Medical School in Newark, New Jersey, where he served as a core teaching faculty member for the Division of Emergency Medicine from 2004 through 2007. Dr. Gluckman has extensive experience in pre-hospital and hospital emergency preparedness, authoring several book chapters on disaster medicine, and is one of the authors of the New Jersey State Police course manual entitled Hospital Emergency Department Operations Hazmat WMD Hospital Provider. He continues to serve as a consultant and instructor for the New Jersey State Police Hazardous Materials Response Unit. He is a trained hazardous materials technician and serves as the operational medical director for the Morris County, New Jersey Special Operations Group, which includes the SWAT team, bomb squad, and the hazardous materials unit. Dr. Gluckman is one of a selected group of providers in New Jersey trained to administer the smallpox vaccine and respond to a smallpox outbreak. I should add that he's demonstrated great skill and expertise in representing UC-AOA and its urgent care members publicly. He joins us now to talk about the appropriate clinical response to the Ebola virus in much greater detail. Dr. Gluckman.
Great. Thank you, Steve. Really good job and important messages there from the administrative piece. As Steve says, I'm going to focus a little bit more on the clinical aspects of Ebola. I think if we have to take away one message from all of this is we really do need to stay calm and stay cool. We're going to give you the information you need to help you and your staff maintain the calm, understand a little bit about the disease and how we can be prepared to keep our employees safe and our patients safe. Let's start with some of the basics. while by now many of you are probably already familiar with this, but I just want to reiterate that Ebola is transmitted via contact with infected body fluids, saliva, emesis, stool, urine, semen, and breast milk can also be found in there as well. It can also be transmitted via contact with contaminated needles or syringes and through contaminated animals, but this is typically found in Africa and not wild animals running around in the United States. As we know right now, and this is the most important thing, it is not believed to be transmitted via the air, not through water or other food sources in the U.S. The airborne transmission piece is the biggest controversial area, which is getting people really scared unnecessarily, and I'm going to go into that in greater detail in future slides. So what is the primary focus for urgent care providers? They're really twofold. One is to prevent exposure. And how do we prevent an exposure? Obviously, prevention in any area of medicine is the best, and certainly better than treatment. We want to prevent exposures through proper triage, whether that be through phone triage of patients calling in, being concerned about possibly having Ebola, or at the front desk when they do arrive. And we'll talk a little bit about some triage protocols, which can also be found on the UCAOA.org site, as Steve mentioned, under the Ebola resources. The other thing we want to do is prevent contamination. So if a patient does inadvertently present to an urgent care center, you want to try to avoid contact if at all possible. Again, this is not an airborne transmission. It is only through transmission through infected materials. So if you don't come in contact with those sources, you cannot become infected. If we need to make contact with a patient, the use of appropriate personal protective equipment such as gloves, fluid impermeable gown, mask, eye and face protection will be necessary. So let's talk a moment about the phone triage. Again, you will be able to find this written on the UCOA website, but basically we recommend that your front desk staff who answers the phone and potentially has a patient that's concerned about Ebola, that they obtain the caller's full name, address, and callback number. They should then proceed with asking about high-risk symptoms for Ebola, which include fever, abdominal pain, vomiting, headache, muscle aches, and unexplained rash or bleeding. They should then ask the caller if he or she has recently traveled to West Africa or any currently affected country or region within the past 21 days. They should also ask if the caller has had any contact with any known person infected with Ebola within the last 21 days. This will help identify those potential healthcare workers that may have been involved in treating an Ebola case in the hospital, not necessarily somebody coming in from West Africa or foreign travel. If the answer to travel or exposure questions are no, then the caller can be seen at an urgent care center. If the answer to travel or exposure questions is yes, and the caller has any signs or symptoms, then we have to treat this as a potential exposure and not recommend that they come to the urgent care center. Remember, somebody that just is coming from an infected country such as West Africa, if they don't have any signs or symptoms or any illness, they aren't infectious, they aren't contagious, and we may consider them safe to evaluate. Only if they have the symptoms in combination with the travel history do we get concerned. So anyone that does have the symptoms listed previously and a travel history, they should be instructed to call 911, relay to them their concern about a potential Ebola infection, and allow them to transport the patient to the hospital via EMS. You should not instruct them and discourage them from going by taxi or public transportation to prevent further exposure to unnecessary personnel. This is the time, if you haven't done so already, to develop your partnerships with your local 911 dispatch centers, your emergency medical services, and your local health department or health officers and emergency departments. Hospitals currently are working on their plans for receiving patients from EMS. And this is a perfect time for urgent care centers to begin working with them and being included in their plans. So let's talk a little bit about personal protective equipment, because this is what has people so crazy. You know, we have some people talking about potential conspiracy theories about the CDC recommending inadequate protection. Do as I say, not as I do. We all see on the news and in the press, everyone that's taking care of Ebola patients or transporting them are all in higher level gear and protection than what the CDC guidelines currently recommend. The CDC is about to imminently release new guidelines for preparation of dealing with patients with Ebola, but I do want to mention and emphasize that these are really going to be designed for people, healthcare providers, that are taking care of infected patients. I really don't think that they are designed for the average urgent care provider who's going to be doing mostly evaluation. So let's try to get a handle on this and go into a little bit more detail. So currently the guidelines as of right now recommend that healthcare workers, when dealing with a potentially exposed Ebola patient, wear at a minimum a fluid and permeable gown. This does not necessarily mean a complete full Tyvek suit. This can be a typical surgical gown that's water impermeable, gloves, a mask, either with a face shield or in combination with wraparound eye goggles, and consider the use of a head cap or booties for additional protection if splash is considered. So in reality, is this really adequate? If we look at basic hazardous materials protocols or procedure, the assessment is done by doing a risk assessment. And this should really be looked at no differently. Do they just have a fever? Do they have body aches and abdominal pain? Or are they vomiting, bleeding, or having diarrhea? Are they in extremis? Are they really, really sick? Or are they pretty comfortable, walking on their own power, mentating normally? These are assessments that we really need to do and will help drive your determination of a level of PPE to use. I wanted to bring this up, again, to help calm some of the fears and concerns about Ebola. While we do recognize that this is a serious disease and has a high morbidity and mortality associated with infection, realize that because it's not airborne transmission, that the likelihood of infectivity is much lower than many other diseases. And you can see mumps and measles are much higher, much more likely to transmit disease. And what's not on this slide are things like enterovirus and influenza, which infect many more patients much more easily. Just throwing out there, think about the first flu patient that comes into your clinic. How do we treat that patient? So getting back to PPE decision making, again, if they just have a fever or abdominal pain, they're not bleeding, they're not vomiting, they're really at very low likelihood for spreading disease to anybody else. You're not going to become in contact with their infected body fluids. So a mask with a face shield and gloves is more than adequate, in my opinion, to deal with them, to at least interview them and assess them. You certainly want to get a little bit better handle on what their situation is and determine whether this truly is a high-risk Ebola patient. So you do want to limit your contact to only the essential evaluation, limit your personnel to ideally only one or perhaps two individuals. You may not even need to lay a hand on them and examine them. You can do this even more safely from a distance by just asking them some additional questions, referring back to the CDC questions about exposure and confirming their recent travel to an infected area. And if you determine that that patient does meet criteria for a high-risk patient, you don't need to go and start taking vital signs, touching them, or examining them. You will do your best to just isolate them and notify 911 for appropriate transfer to the hospital. Now, however, if they are bleeding, having vomiting, diarrhea on your exam table or floor, then you have a full court press, and the patient should be approached with appropriate PPE. But in my opinion, you have to make a decision whether you have to be that individual to do it or not. If they are stable, I would say you don't even have to go in and deal with that. Call your local EMS and call your hazmat team. These are the personnel that are trained, well-equipped, practice this on a regular basis, and can make the entry more safely than a medical provider in the urgent care. Let them go and take the patient. I think that it's pretty unrealistic to have all urgent care center personnel competent to dress up in full level C attire, and I'll explain a little bit more in just a moment. Again, this is my recommendations based on solid, sound hazmat principles and experience, but you and your center need to develop your own policy. As Steve mentioned before, you should discuss this with your administrators and your medical director and make a decision what is comfortable and right for your center. So let's take a quick look at some of the PPE, and I'm going to go over some donning and doffing procedures. Currently, this is the basic equipment that the CDC recommends and is at a minimum, and what I feel is probably adequate for the urgent care environment. We have gloves, masks with a face shield, additional eye protection, and a water impermeable gown. So why is it that everyone on the news is in spacesuits? Well, we mentioned that before, and that new guidelines are expected out from CDC today. I do anticipate that they are going to recommend more total body coverage, including using sort of head shield, as you see down there, with a PAPR, and booties, additional protection so that no skin is exposed. But in reality, it's not unreasonable for healthcare workers that are heavily engaged in the treatment of known Ebola cases to take those extra precautions. In the hospital, when they're really sick and they are having a lot of diarrhea and vomiting, the splash likelihood is much higher. Thus, their exposure and their risk assessment dictates that you use a higher level of protection. What you see here is the use of a powered air purifying respirator, which a lot of them are using. Again, this is not necessary from a respiratory standpoint, but rather they're using this because it's more comfortable to work in, it's blowing fresh air onto them, it's easier to work in, and it keeps their face shield from fogging up so that they can actually do their job with greater ease, and they're less likely to have to bring their potentially contaminated hands up towards their face to wipe the mask. So again, I just want to emphasize, they're not really doing this for respiratory protection, but for other reasons. This extra higher level of respiratory protection is not needed because it is not an airborne transmitted disease. And I strongly feel that urgent care centers do not need to have this level of protection because we are really screening patients. We are not treating them. The likelihood that we are going to get a severely ill, highly infectious Ebola patient is pretty low. It is much more likely that we are going to see somebody who has a fever, abdominal pain, body aches, flu-like symptoms, but is not an extremist and not at high risk for spreading the disease. So again, why don't we wear these spacesuits in the urgent care? It is overkill, as I just mentioned, and what's really not talked about is there are unintended consequences of wearing this higher level of personal protective equipment. It comes with potential dangers. If you have not ever worn a full-body Tyvek suit and all of the other equipment that you see on the news, there is a significant increase in stress, both heat stress and cardiac stress, particularly in warm environments. If you're in a very warm area of the country, you can become dehydrated and physically exhausted much more quickly while wearing this type of attire. It is very awkward. Wearing the booties and being taped up limits your mobility, and unless you're used to it and comfortable with it, You may lead to unnecessary falls, which could increase the risk for potential injury. If you're wearing a PAPR with a blower and a motor, it increases the ambient noise and can make communication a little bit more difficult. And if you go to the extreme of using either a half or a full face respirator, that really increases your heat stress and your stress overall by breathing through a tight mask, which makes it more difficult. And it adds an additional factor of you, the center, requiring that they be medically cleared and fit tested per OSHA guidelines. So again, I really think this is overkill for an urgent care center. A big question, will I need to close my center down? And the answer is not necessarily. You certainly will need to confer with your local health officials. If there's no contamination, there's no definite need to close. It's not an airborne hazard. It's not going to creep from one room to another. You would certainly have to cordon off any potentially infected area. But again, this is going to be the ultimate decision made by your local health authorities. Do I need to quarantine everyone in my center? The answer is no. This is, again, not spread to casual contact. You should keep the names of patients in case the health department wants to follow up with them. And I just throw out there appropriate decontamination solutions. Okay, this is the current recommendation from the CDC, and we have this posted on the website as well. I am going to show you in a moment some quick donning and doffing techniques that do add a little bit extra layer of protection, in my opinion, from what the CDC guidelines are. So let's start. First, start with just a simple pair of gloves. This is going to go on the inside of your gown. You go ahead and put on your gown, your water impermeable gown, and secure it like you normally would. Notice that the gloves are on the inside of the cuffs. This is going to keep the inside portion of those gloves a little bit better protected, so that when we go to take them off, this is an area where you have a potential risk for contamination. After you put on your gown completely and secure it, you would place a second pair of gloves on over that so that it is over the cuff, which I will show you in a second, and then place on your mask with a face shield and or goggles. In this picture, I demonstrate having both goggles and a mask with face shield. On the right side, you will see people that are fully dressed up with hoods. That obviously affords a little bit better protection around the neckline and the head, and I think that this is where the CDC is going to increase and change its guidelines to the use of this protection, because it does clearly afford better splash protection of the neck and head region. If we don't anticipate this in the urgent care, again, dealing with a patient who has a fever and you're only talking to, splash protection of your head is not necessary. Here's a close-up picture of the gloves going over the cuffs. And to remove it, the simplest way is to grab by the chest and pull your gown down. We're going to remember the inside of your gown is essentially clean. So that's the area we're going to want to get to safely. So take it forward. And then as you're pulling that gown off, you want that outer pair of gloves, the white ones shown here, to be inside of each other. I've already taken one off. I'm now taking the second one off, folding it up inside of it and inside the gown, allowing the blue gloves to stay essentially clean. Dispose of this in an appropriate container. Remove your mask and face shield, and then remove your second layer of gloves, or blue gloves, closest to your skin, using standard means from the inside out. Follow this by washing with normal soap and water and potentially an alcohol-based hand cleaner afterwards. So in summary, the really important pieces here to take home is to stay calm. There really is no need to panic. We need to develop procedures for triage and prevention of infection in the first place. If we can identify patients while they're at home and calling us, we don't have to see them in the urgent care. However, if patients do present to us, we do have to be prepared how to manage them. Make sure that your staff is trained, that they know where your PPE is located and how to use it. Take this time now to identify your key contacts in your area and have this list of contacts available. Again, your health officer, the health department, your 911 dispatch center, your emergency department charge nurse. Okay? During a disaster is not the time to be handing out business cards. So this is the time to prepare. So at this time, I'm going to entertain some questions. If you give me a moment, I'm just going to look through the list as they've been coming across, and I will do my best to answer some questions. If you haven't already asked it, please go ahead and add that into the chat box, and I will do my best to answer them. So I have one question. When removing, do you do it inside the room or outside the patient room? I would do it inside the patient room, limiting your exposure to other areas of your center. Do you ask your current patients to leave if you have a suspected case after you get information for further contact? If you have patients in your rooms already, I would maintain them in their rooms and limit their contact while you're transferring the patient into a single room and isolate them as best as possible. Unless they are, I'll take that back. You don't need to have any of them leave. If the patient is an extremist and is contaminating the area, then you do want to maintain them all for EMS and hazmat to come so that those patients may be appropriately evaluated and decontaminated. Question, is there a spread through sweat, such as on a doorknob? Certainly any kind of infected material, such as sweat, may be a possibility of contamination. So when you're bringing them back into a room, I would suggest telling the patient not to touch anything, keep their hands on their chest, and the employee that's walking them back to the room do all the opening of the doors until they get into the room and secure them. How long will the virus stay alive on inanimate objects? That question is still a million-dollar question. There are some studies that show it can be up to 6 days. However, some studies that were done in the actual environment in Africa showed that unless it was really involved with a contaminated fluid such as blood, that it was not found to be on other objects. At this point, I think until it's better clarified, we should treat it as a possible means of transmission for at least a day. During the phone triage, is it required that the urgent care facilities document any monitoring within the medical record, even though the patient has not visited the facility? That is a good question. I think any time that you give medical advice, you should be documenting somehow in the system. Obviously, a lot of EMRs require you to register the patient in order to generate a chart for you to document in. This might be an opportunity just to keep a record for now in a separate file, at least notes of who you spoke to, their contact information, and the recommendations that you gave, rather than putting it in the EHR. Should you have a patient gown, glove, and mask? Again, looking at what their chief complaint is and what they have, if you truly believe this is an Ebola patient and they are, for whatever reason, sneezing and potentially coughing, spewing droplets out, putting a mask on them would be of benefit. But if they are just complaining of something like a fever, abdominal pain, or headache, body aches, there's no need to put that patient in any kind of personal protective equipment, and at most putting your provider in it alone. What if the local health department doesn't have a good answer for triage for you? I certainly can understand that some health departments are also clamoring for information from their state health departments and from the CDC. I know that that information is being actively pushed to the local health departments in as quick a fashion as possible. I think the health officer is the one that really has the ultimate authority and decision-making as to whether or not a patient needs to be quarantined. So it is going to fall on their lap. I expect that if your particular health department doesn't feel comfortable with the answers they're getting, they probably will in the very near future, because that information is continuing to flow to them on a regular basis. Should protective gear be put in a red bag? If it's been utilized and contaminated, yes, it should go in a red bag. And if it has been truly infected, this actually has to go through even more specialized transport per DOT regulations. You would have to call and speak with your hazardous materials transport provider to determine the best way to do that and if they're able to do it. Are the plastic blue gowns, very thin, without cuff sleeves, acceptable for PPE? I think I know what you're referring to. Those would not be considered acceptable. They are pretty thin, and if you don't have a cuff on them, you're really not providing the adequate protection at the wrist area, which is a high area for contamination. So I would suggest that you pick up standard surgical gowns, which meet the criteria from a water impermeable perspective, and they provide that extra wrist protection. If you are exposed and unaware, what is the estimated period of time before symptoms present themselves? Right now, they believe the incubation period is between 2 and 21 days, with an average being between 8 and 10. So this is where the 21-day quarantine period has come from. So if you haven't developed symptoms for 21 days after a suspected or known exposure, then you are considered to be free. Recommended triage in-house. Do front desk personnel perform this triage? This would be something that you would develop in your own center's policies. For UCAOA members, we are going to be putting up some sample policies in the member-only section that you can refer to and reference. You can do this either way. You can either have your staff, your front desk staff, run through the quick triage first, and if there's any positives at all, that the provider be immediately notified and the patient roomed, and then have the provider go through those in greater detail and determine if it sounds like it's a legitimate exposure or Ebola case. What should be the plan for the staff that cared for the patient after a patient is transferred to the ED? Do the healthcare workers continue to care for other patients? This will have to be looked at on a case-by-case basis. Again, if it's somebody that the healthcare provider has not come in contact with them with any of their bodily fluids at all and has done their history just by standing apart from them and spoken to them, wore PPE and washed up afterwards, there's no reason to believe that they have become contaminated or infected, and thus they are not infectious to other people, and they may go ahead and continue to see patients. If they did get involved with a patient that was vomiting, had diarrhea, or had bloody contamination in any way, they should certainly, I would recommend that they be relieved of duty to at least go and shower afterwards after removing their PPE in an appropriate manner. Would you recommend cleaning first and second gloves with an appropriate disinfectant prior to taking them off? There's certainly no harm in doing that. There are certainly Doctors Without Borders in these countries taking care of patients will routinely use a bleach solution for their on their gloves before removing them. Again, if there's no contamination, that would be, I think, an unnecessary and overkill step. However, if you have it available, there's certainly no harm in applying a bleach solution or alcohol cleanser to the exterior of your gloves prior to removal. If you get a suspected patient, should you ask them to leave after getting info for follow-up versus isolating? We would not want to let a suspected patient go. If you have a suspected patient, you really should isolate them. If you let them go, where are they going to would be my question. Are they going off to the emergency department via taxi or the bus, and then potentially exposing all those patients, those people on the on public transportation? If you have somebody that you've identified as potentially infectious, you should isolate them to the best of your abilities and have 911 transport them to the hospital. When a patient answers yes to travel to West Africa and has all the flu symptoms, where would you recommend we place them in the clinic? You would have to determine that based on your clinic layout. I would certainly recommend the furthest room from your waiting room, but whatever one is available, readily available. And again, as long as it's a single patient room, if your clinic has something where it's separated by just a divider and not isolated room, that would not be good. It should be an individual room. Anywhere is adequate. And again, have your staff open the doors for them. Don't let them touch anything that they don't need to. How should front desk reception handle patients who may present with symptoms of Ebola? Should they be collecting insurance cards, et cetera? If your screening has determined that they're a potential Ebola case, they should be brought promptly into a single room, and the provider should do a further history to determine the necessity. If it is determined that they are potentially infectious, I think the information can be obtained later, or if you really want to collect it at that time, the patient can remove it from their wallet and read off the information to the provider who can document it or take a picture of it. I would not have the patient take and touch their card, potentially infect the card, give it to you or your staff, and allow it to spread through contact of potentially contaminated sweat or urine or any other bodily fluids. You mentioned phone triage. For in-office triage, should we have all patients coming in, do a quick screening questionnaire, or only with symptoms? Again, that's something that you would want to discuss with your administration and your medical director. A lot of clinics are putting up signs and notifying patients ahead of time that if you have any of these symptoms or you've had travel to the area, to please notify the front desk staff immediately. I think that's a very good idea. What is the laboratory workup for suspicious of Ebola? We would not want to do this in the urgent care center. To answer your question, there is a sample that needs to be drawn and sent off to the CDC. That's only done after consultation with the health department, who gives you an authorization to do so. I would strongly advise that you not do this in the urgent care setting. It just leads to additional exposure by drawing their blood. These patients are better managed in an emergency department and hospital where they can properly be isolated and the blood test sent there. So again, to limit your exposure and limit exposure to your personnel, I would strongly recommend not doing any blood tests that are not necessary. We don't need to make the diagnosis in the urgent care center. Is it a good idea to have my staff clean the room after the infected patient leaves, or should we call it professional services? If you truly believe that this was an infected patient, the health department's going to be involved. They might mandate that you have a professional service do it. If there was any contamination whatsoever, I would certainly recommend a professional service do it because they're going to want to properly gown up because there is a greater splash hazard when you're spraying disinfectant around that would lead to a potentially unnecessary exposure to your staff. So I would have a professional service clean that and not have your staff do it. If there's really essentially no risk for contamination, patient has a fever only, having your staff wipe down as they normally do after any patient with an appropriate disinfectant is certainly wise. If the patient in the clinic is a high-risk Ebola patient, should the front doors to the clinic be temporarily closed until patient is safely transferred? Again, that would be a decision you would want to discuss with your administrator and your medical director. Depending on where the patient's located, if they're in a back hall room far away from your operations and your registration and your waiting room, I don't think it's unreasonable to continue your operations. You may not want to bring additional patients back into your clinic rooms at that point. You can keep them in the waiting area, but it wouldn't be necessary to close them down. If you have a small clinic and the patient is really close to the waiting area or is still in your waiting room, it might be wise to prevent additional patients from entering until you have it secured. We have a moderate volume of immigrant patients from West Africa who have no known exposure history. They are likely to develop symptoms of influenza. They do have occasional travel history. What is your recommendation for managing those patients? Isolation of all seems excessive, but that is true. Common things being common, yeah, it's more likely that a patient traveling from there that comes here during flu season develops the flu, but it is really essentially impossible for us to make that differentiation. And to err on the side of caution, anybody that has a travel history within 21 days to a known infected area and presents with any of those symptoms should be treated seriously as a potential Ebola case and should be isolated. Let the hospital and the health department sort it out, do definitive testing, and determine that it really was just the flu and not Ebola. But we need to err on the side of caution and isolate those patients, however many they may be. If you do have a large volume of those cases, you should especially be in contact with your health officer and your hospital and try to develop some streamlined processes for doing that. Where can we obtain the posters for waiting rooms that you discussed? There are some posters available on the CDC website. Some of them are being made up by individual clinics, either on their own sort of stationery and the like. I'm sure that's something else that we are going to add to the UCAOA website for members to help them. But it would be pretty easy to generate your own with your own logos on it based on the simple questionnaires, which we do have available to the general public. If there is a lot of diarrhea or vomiting, should double gowning occur? You know, if you're going to get involved with a case like that, that is where clearly a full Tyvek suit would be beneficial, or a gown with booties and better protection. Probably no harm in double gowning other than increasing the heat stress, but Again, I would discourage you from actively getting involved with the treatment of a patient like this in the urgent care center unless they are an extremist and you feel like you medically, ethically have to act. If they are just vomiting, let them stay isolated and vomit. The cleanup can be done later, but for you to put yourself unnecessarily in harm's way and expose yourself, I think is unnecessary. If a patient you suspect by phone triage may have Ebola and you recommend that they call 911 and they refuse, should you call 911 and give them the patient information, breach of HIPAA? So I don't want to touch any legal issues because I don't think there's any case law to substantiate a good answer here. I think if the patient's going to refuse that, I would recommend then that they stay at home and treat themselves there. If they get sicker, that the right answer is to call 911 and go. Then strongly do the best that you can to encourage them to call 911. Unfortunately, we don't have control over everything and everybody, and if that patient does choose to go by vehicle, they're going to do it. We can just give them the best information that we can and hope that they take our advice. What about shoe covers or leg covers, and when are they removed during the removal process of PPE? Again, additional covers such as for the head and for leg coverings would be useful and recommended if you're anticipating splash hazards such as vomiting or bleeding or diarrhea. If you're going to do that, it would be done, you would want to put that on, but again, thinking back to what I've said before, trying not to expose yourself unnecessarily, I wouldn't necessarily go there in the urgent care center. If you have them available and you do want to utilize them for additional protection, you can certainly do that. You want to take those off first. With your, after you take your gloves off, the next step would be removing that. If the patient is screened and transferred in, sorry, this isn't, I have to decipher this one a little bit better. If the patient is screened, transferred from an urgent care center, and ultimately tests positive for Ebola, should the urgent care and health center workers involved be quarantined for 21 days? That is going to be a decision by the health department. That's not something that we would decide. It is quite possible. That's what we're doing now. Close family members and healthcare workers are the ones that are at highest risk. So the health department might very well order a quarantine for the healthcare provider that took care of them. Another reason to limit the contact of your staff to only essential personnel and ideally one person. If the possible infected patient travels in the clinic with family members, what do we do with the family members? I would question the family members about symptoms as well, and if none of the family members are symptomatic, they're going to be treated as any other patient in the clinic. If they're not exhibiting symptoms, they don't have a fever, they don't have any symptoms, they're not considered infectious, so they should obviously be kept away from the patient as much as possible as well to prevent any further contamination, but you do not need to do anything special with them. You're going to notify the health department, and they will continue to monitor those family members. We don't need to do anything specific or special for them. How long should we keep the room isolated after the suspected patient is transferred and the room has been disinfected before other patients and staff are allowed to enter the room? The health department is going to want to chime in here, but according to World Health Organization, if you've decontaminated with a bleach solution for 10 minutes, that is considered adequate. Some of the centers in the U.S. that are treating these patients do have a more extensive decontamination protocol, which can last up to a week long, where they allow the infectious material to dry out. They give it a bleach cleanse. They dry it out some more. They do another bleach cleaning, dry it out. So these protocols have not been established as of yet. Again, we're going to have to consult with our health department how we would proceed with that. At this point, if there was significant contamination, I would say it's fair to say that it would be at least a day until somebody of the decision-making power in the health department comes up with a response for you. What if they are symptomatic but don't have a fever? So this is a trickier one. Most patients will present with a fever. However, they may be afebrile at times. They may have just taken some Tylenol or Motrin and be afebrile. So if they do have any of the other symptoms, in addition to a travel history, you do have to consider them a potential Ebola infected patient and transport them and handle them accordingly. This is a discussion, the health department would get involved with this and question them even further. But again, that patient probably should be treated the same as if they did have a fever. Okay, at this point, I don't see any additional questions. And we are.
Yeah, that is all the questions that we have right now. So unless any other ones come in, but we're almost at 2 p.m. So I just wanted to let everybody know that this webinar has been recorded, and it will be available to all of you and anybody else who hasn't been on today's webinar. We'll have it on the UCAOA website for everybody. And we'll also make a PDF of the PowerPoint available. So if there aren't any other questions, I'm going to go ahead and thank you all for joining us today. Thanks to Steve Sellers and Dr. Gluckman for all their information. And this will end today's webinar. Thank you.